fourth presentation. Dr. Gerardo Antonio Umanzor Funes, who's a medical oncologist with Centro Oncologico Integral, is going to be presenting the oral paclitaxel with encequidar, the first orally administered paclitaxel shown to be superior to IV paclitaxel on confirmed response and survival with less neuropathy, a phase 3 clinical study in metastatic breast cancer. And my one pertinent disclosure for today, I'm a scientific advisor for Athenex, which is the company that provides the drug, unpaid.
Thank you. So on behalf of my co-authors and the OPE team, thank you for asking us to present OPE, which is oral paclitaxel with encequidar, a phase 3 clinical trial of oral paclitaxel with encequidar compared to IV paclitaxel in patients with metastatic breast cancer. I do not have any disclosures. So taxanes remain a foundation of breast cancer treatment with several IV dosing regimens that are used in clinical practice. As an oncologist, it has been very frustrating to have an effective chemotherapy like paclitaxel, which a lot of patients cannot tolerate. So the therapy used in this phase 3 study, oral paclitaxel and encequidar, was designed to overcome this issue. There are multiple benefits associated with oral administration, including patient convenience, a lack of need of IV access, a lack of infusion, hypersensitivity reactions. So paclitaxel is a substrate of the intestinal efflux pump, P-glycoprotein or PGP, and that results in a low oral bioavailability. But encequidar is a minimally absorbed, highly specific, potent inhibitor of PGP, which increases the absorption of the paclitaxel. So OPE is a combination of oral solubilized paclitaxel and the PGP inhibitor encequidar. So here I will introduce the dose justification for OPE. A pharmacogenetic studies, phase 1 study, comparing OPE 205 milligrams per meter square per day for 3 days to IV paclitaxel 80 milligrams per meter square, showed that total exposure to paclitaxel was comparable between the two arms with a lower peak concentration of OPE compared with the IPE formulation. We hypothesized that the lower peak concentration of the OPE might result in lower systemic toxicity. In a phase 2 study, 26 patients with heavily pretreated metastatic breast cancer were treated with the OPE 205 milligrams per meter square daily for 3 consecutive days, repeated weekly, and demonstrated encouraging clinical activity with a partial response of 42%. Now moving to the phase 3 study of OPE in metastatic breast cancer. This pivotal phase 3 open label randomized patients with any type of metastatic breast cancer in a 2-to-1 ratio to receive OPE for 3 consecutive days each week to IV paclitaxel according to the labeled dose of IV paclitaxel 175 milligrams per meter square every 3 weeks. The primary endpoint is blinded, independently reviewed, radiologically confirmed tumor response, including complete and partial responders in 2 consecutive time points, 3 to 6 weeks apart, using the RECIST criteria. Imaging was performed in weeks 10, 16, and 19, and in patients with a complete or partial response at week 19, a confirmatory scan was completed at week 22. The primary endpoint final analysis was defined as the date that the last enrolled patient had their last scan within the 22-week study period. Patients with stable or responding disease could continue on study therapy for the extension period of this trial. Additional endpoints were safety and tolerability, progression-free survival, and overall survival. Sorry. Well, I want to say also that the study was powered based on the modified intent to treat population, which included 360 evaluable patients for a p-value of 0.045, which would confirm tumor response rate and was considered significant. The study was conducted in 45 sites in South and Central America. So inclusion criteria included patients with a diagnosis of metastatic breast cancer with measurable disease at least 1 year from last adjuvant or metastatic taxane and an ECOG 0 or 1. Patients with central nervous system metastases were excluded. And looking at 2 of the pre-specified analysis populations, we have the primary endpoint was based on the pre-specified modified intent to treat population, consisting of all patients with a baseline evaluable scan and who received at least 7 doses of OPE or 1 dose of IV paclitaxel. And these 360 patients comprise the primary efficacy population. The intent to treat population included 402 randomized patients. The patient demographics were balanced between the 2 treatment arms, and a similar percentage of subjects in each treatment group received prior taxane therapy. Now, introducing the dosing regimen of OPE. OPE is comprised of 150 milligram tablet of encequidar given by mouth prior to the oral paclitaxel, 205 milligrams per meter square for 3 consecutive days each week for 3 weeks without a break. 9 doses of OPE represent 1 cycle, or 3 weeks. No prophylactic corticosteroid or antihistamine pre-medication was allowed for the OPE arm, and IV paclitaxel was administered at 175 milligrams per meter square over 3-hour infusion every 3 weeks, representing 1 cycle. Okay, now to look at the study's primary endpoint, overall response rate in the pre-specified MITT population, treatment with OPE resulted in a significantly improved, centrally confirmed response rate of 40.4%, compared with 25.6% with IV paclitaxel, with a p-value equal of 0.005 and representing an absolute improvement of 14.8%. These results were further supported by a significant improvement in overall response with OPE in the ITT population, with an absolute improvement of 12.4% and a p-value of 0.011. In addition, tumor response in all clinically important subgroups was consistent with the overall confirmed response profiles. For the study's secondary endpoints, at the time of the data cut for the primary endpoint, PFS and OS data collection remained ongoing. A non-significant trend, numerical trend was seen for median PFS, favoring OPE, median 9.3 months for OPE and 8.3 months for IV paclitaxel in the MITT population. Also, in the MITT population, an early analysis of overall survival was significantly improved with OPE at 27.9 months versus IV paclitaxel at 16.9 months with a p-value of 0.035. Regarding the safety profile, I would like to highlight that chemotherapy-induced peripheral neuropathy in particular, as this is a highly debilitating side effect of IV, and the difference between these arms is quite dramatic. OPE is associated with lower incidence of severity of neuropathy compared to the IV paclitaxel. For neuropathy overall, 57% was presented in the IV paclitaxel versus 17% in the OPE group. The incidence grade of grade 3 neuropathic symptoms in the OPE group was only 1% versus 8% in the IV paclitaxel group. The toxicity profile of OPE was generally similar to IV paclitaxel. There were higher rates of neutropenia, infection, and gastrointestinal AEs, but these were low grade and were manageable. In summary, oral paclitaxel and encequidar is the first oral taxane to demonstrate improved and durable confirmed overall response to, compared with IV paclitaxel given every 3 weeks. Oral paclitaxel and encequidar significantly improved level in the modified intent to treat population compared with IV paclitaxel. In addition, responses were durable for oral paclitaxel and encequidar. Oral paclitaxel and encequidar was associated with lower incidence of clinically meaningful neuropathy and alopecia, and a higher incidence of low-grade in gastrointestinal events. Oral paclitaxel and encequidar provides an important oral therapeutic option for patients with metastatic breast cancer, representing a meaningful improvement in the clinical profile of paclitaxel. In conclusion, on behalf of my co-investigators, I would like to thank the patients, families, and investigators who made this study possible. Thank you.
We'll take some questions. I did a quick calculation. It looks like an average patient would be receiving 11 tablets of the oral medication.
Yes,
per
yes,
dose?
that's about right. Yeah.
So 11 tablets per dose.
Yeah, it's 11 capsules,
Capsules.
because you get the tablet for the encequidar.
Was there an issue with adherence?
Well, we had the doubt at the beginning, but no complaints at all. Patients were so excited that they were getting an oral treatment, and we had a very good compliance. So we didn't really have any trouble with adherence at that point. We had to do a crash course to teach them how to take them, but no problems there.
And the patients for those 3 days took the medications at home, or did they come to your clinic?
Yes, they would take the first dose there when we were with them, and then they would take it at home. So I think they were happy about that, and that's why I think they were happy.
Excuse me. Charles Bankhead, MedPage Today. I have a question sort of about the technology. Would this approach also be useful for other taxanes, such as docetaxel, cabazitaxel?
Yeah, I mean, I cannot answer that directly because I'm just the medical oncologist using it. Hopefully, yes, it could open a door for other treatments. It's definitely exciting with the encequidar, but I cannot answer that straightforwardly.
And the answer is yes, that there are other oral taxanes that are being looked at in this approach as well, yes.
So you see.
Marisa Weiss, breastcancer.org. Two questions. What is the encequidar doing? That one arm got it, the other arm didn't, and so what role does it play? And my second question is, will the drop in reimbursement to medical oncologists when patients use an oral agent rather than come in for IVs be a barrier to the utilization adoption of this new approach?
So the encequidar is given to the oral paclitaxel because what it's doing, it's blocking that pump in the intestine, which is PGP, a P-glycoprotein, that allows for the oral paclitaxel to be absorbed and be bioavailable. You don't need that in the IV because it goes straight to the bloodstream. So that's the main function of the encequidar, to allow for the oral paclitaxel to be absorbed. And for the second, I wish I could have an answer, but first, I'm not a US-based, and then we will have to see how it works out.
I'll answer the question, and Dr. Slabowski can also pitch in. We have several oral medications, and so financial issues do not preclude us from prescribing them, and we prescribe them all the time. I think there are other issues with oral medications, such as how soon does the patient get them? The fact that the physician may not be in control of that. With this medication, given the fact that it may end up going into the oncologist clinic instead of an outpatient pharmacy, it may end up being a little bit easier, but we use oral medications all the time.
Yeah, and I guess the other part is the world is changing very rapidly, and there's fewer deciders now. So basically, many groups have multiple practices, and then one person can decide, and so in the next few years, it's going to change even more.
Manasi Vaidya, Biopharm Insight. I had a question about the schedule of paclitaxel that was studied in this trial. Since there's a weekly paclitaxel dose available as well, could you comment on how the choice is made between these schedules, and if these results could also apply in comparison to the weekly paclitaxel dose?
Yes, so basically the dosing schedule was decided upon that this is a label trial. So the FDA has approval for 175 milligram per meter square, although in clinical practice, there's a use of the 80 milligrams per meter square, but we have the data for the safety profile and results for the 175. And although the 80 is used, it's not really been submitted for the FDA approval. So since it's a label trial, that's why that was the dose used.
And I think that that is really a limitation for the clinical trial. We've had several other trials showing that the weekly dose is more efficacious than the 3-weekly dose, so this is definitely going to be a limitation for this trial. What
we can say is that we do believe that with the area under the curve that we see with the oral paclitaxel, we have a potent drug, and we believe that hopefully is gonna make practitioners to be comfortable, because it's a very active drug and you're seeing results, so in overall response rate and overall survival, so I think that's the plus side.
I'm sorry, just to clarify then, do you think these results need to be seen in the context of only the ones in 3 week? Should these results be analyzed only in the context of the dose that was studied in the trial, or also perhaps considered with the weekly paclitaxel dose that's used in the clinic?
So for now, we're focusing on this dosing and in this trial, because we think we have such powerful results, and we think that we have such compelling results, and hopefully this is going to go forward. And that's going to be, the data is going to speak for itself.
I have 2 questions. What was the incidence of alopecia? I didn't see a slide for that. I'm not sure if I missed that.
Yeah, I think we're going to see a little bit more specifics on that on the oral presentation, but it was definitely lower for the oral paclitaxel. We have about 50% less alopecia for the oral versus the IV, so that's really relevant. Yeah, but we'll see more data on the oral.
And also, a couple of years ago, I reported on I think it was a phase 2 study of tezactaxel that was reported at ASCO. Is your drug the furthest along in development now? I mean, I know there are other products in development. Is yours like most likely to come to market first?
I don't know. Hopefully, yes.
I don't know how big a race this is.
Trials with tezactaxel have concluded, but we don't have results yet. So this is the first oral taxane clinical trial results available, which is why this is in the press conference.
Okay, thanks.
Thank you.
Lynn Peterson with Trends in Medicine. I have 2 questions. First, could you describe the actual way this is taken? I think the administration could be a little problematic.
Yes, so the patients have to take the encequidar first. There's a fasting period before the whole treatment, because the treatment is both parts, the encequidar and the oral paclitaxel. So there's a fasting period before. Then you take the encequidar tablet. You have an hour to take the oral paclitaxel, and then there was a safe fasting period as well afterwards for safety reasons.
And so if I summarize it, correct me if I'm wrong, but first, let's say you take it in the morning. You have to have 4 hours of fasting before you take the encequidar. Then you have to wait an hour. Then you take the paclitaxel. Then you have to wait another 4 hours before you can eat. Right?
Exactly.
That's, yeah, okay. So given that, could the panel please give us some comments on how you might or might not use this in your practice?
Again, with my scientific committed disclosure, I think this is going to be a limitation for this medication. I think the 11 tablets or capsules are going to be a limitation for our patients. Many of our patients may not be able to tolerate taking 11 tablets. But keep in mind, it's only 3 days a week, so it's not every single day. That's something that is going to be thought about before we prescribe this. The other limitation I mentioned before is that the data is with every 3 weeks instead of every weekly paclitaxel. So again, something for us to think about. Dr.
Definitely.
Swarovski?
Yeah, I would agree that it will be a limitation because it really is a full-time job to take this. And in the neuropathy thing is a big factor, though. You know, we see these things where 25% or more of women who take paclitaxel are left with permanent disability. You know, and so that would be a big selling point. And I think we'd like to see how easy it is for people to do it, because when I'm doing lifestyle interventions, a lot of people looking at it say nobody would do that, and 19,000 people did. You know, so it's so I guess we'd have to see what happens.
Yeah,
This is just a point of clarification. Is it 11 capsules per day that you take it, or 11 capsules total for the week?
It's per day. It's per day, but it's not 11 specifically. You have to calculate the 205 milligrams per meter square. So it depends. Patients might have less. Patients might have more. But thank you. Yeah, that was a very good point, because when we got these patients, they were so happy that they were gonna get an oral treatment. So that's a big factor. Instead of having the IV, I have to go to the IV infusion center, and we were gladly surprised that they didn't have a lot of issues with taking the medication and with the regimen. So I know it's a clinical setting, but they manage it pretty well, and hopefully they're gonna do it in real life too.
Last question.
Okay. You said this was in Central and South America, but primarily where? Could you give us a bit of a breakdown? We've seen some issues with some South American data.
Well, thank you for the question, because it's an opportunity to speak about how it's all over Central America. It's 45 sites. And it's an opportunity to talk about the co-investigators that they've been doing trials for so long. They have so much experience. They have been participating, and you can see from the disclosures, and all of the regulations were followed. We were very keen on making it according to regulations. And most of us, we came back to our countries. We studied in Europe or studied in other countries and are used to clinical trials. And it's a great opportunity to be able to be doing trials in the same way that we've been doing other places in our own countries.
And the FDA will be evaluating all that data, so we'll have the FDA looking at this very, very closely.
Of course.
So I want to thank